CA15-3 tumor marker in monitoring.
Sorry, Dr. Alya, just a second. I'm sorry if I stop you. Dr. Johnson, could you shut down your microphone? Can you silence your microphone?
I'll be here.
I'm sorry, just a second. Dr. Johnson. Dr. Johnson, could you silence your microphone? Okay, thanks. So please, Dr. Alya, you can proceed with your presentation and please put in presentation settings so we can see better your slide.
Okay. Thank you very much. The title of my research is about the reliability of CA15-3 tumor marker in monitoring therapeutic response in different molecular subtypes of metastatic breast cancer. Okay, as you know, metastatic breast cancer remains incurable in the majority of the cases, and treatment only aims to improve the quality of life and survival. So our challenges now is to find marker for follow-up of the patient and evaluate the response. For most of our work, radiological examination is the standard monitoring strategies that have been used widely for the assessment of treatment response. However, more than 30% of the metastatic lesions are not measurable by radiological test.
Dr. Alya, I'm sorry.
Yes.
I'm sorry, we can't see your slides, just the first one. So could you put in a presentation way?
This is in presentation way?
Yeah, but we can see just the first one. And we don't see the second or the other. In the main screen, yes. Now, yes.
But
I have to... Yes. Now. Let's see.
Okay.
Let's see. I think it will take a bit, but you selected the correct icon.
Is it okay now?
It's still small. I don't know why, but let's try again to select the way for full screen.
Okay.
Okay, now yes. Thank you. Thank you very much.
Sorry. Okay, so our challenges now is to find markers, tumor marker for evaluating the response to the systemic therapy. It will be very convenient to find a marker and replacing the radiological test for restaging. And as you know, tumor markers play an important role in many cancer like prostatic cancer, ovarian cancer, for the diagnosis and also for evaluating the response. While in breast cancer, a great deal of attention has been paid recently for the prognostic value of this tumor marker, which is CA15-3. That belong to the big family of glycoprotein encoded by MUC1 gene and expressed on the surface of normal epithelial cells, including those of breast epithelial cells. Because the prognostic factor of CA15-3 in breast cancer in different molecular subtype of breast cancer is not so clear, we did this study to determine the reliability of using CA15-3 tumor marker for monitoring therapeutic response in different subtypes of breast cancer. I mean molecular subtypes of breast cancer. So we did this prospective cohort study that included 83 patients with metastatic breast cancer, those who has measurable lesions that could be measured by response evaluation criteria and solid tumor RECIST criteria, who were treated and followed up in Mosul Oncology Hospital during the year 2017 and 2018. From those 83 patients, we have 51 patients presented de novo with a stage 4 disease, and 32 patients had a history of breast cancer and presented with recurrent disease. All the included patients were followed up regularly at an interval for 3 weeks for at least 16 months and were treated by endocrine therapy, chemotherapy, targeted therapy, and or bisphosphonate according to the National Comprehensive Cancer Network. And for all patients, CA15-3 levels were measured before starting the systemic therapy and evaluated then after every 3 weeks during the course of the therapy. And then we evaluate the response to systemic therapy, whether it is chemotherapy, endocrine therapy, or other therapy, by medical examination, of course, clinical examination, and by 2 medical radiological tests, CT scan, MRI, or PET scan, based on the RECIST criteria. And to investigate the relationship between the levels of CA15-3 response to systemic therapy with the progression-free survival, the patients were divided into 2 groups based on their CA15-3 levels prior to the starting the systemic therapy. We divided them to the normal CA15-3 patient and elevated CA15-3 group based on the first reading of the CA15-3. Then after, the patients were allocated to 3 groups based on the relative changes in the levels of CA15-3 at the end of the 3 cycle of systemic therapy. The first group, we call it the increased group, if there is an increase of the CA15-3 by 10% or higher relative to the pre-treatment levels. The second group, we call it non-increased group, if there is an increase of the CA15-3 by less than 10% relative to the pre-treatment level, or reduction of the CA15-3 by less than 10% relative to the pre-treatment level. The third group, we call it decreased group, if there is reduction of the CA15-3 level by 10% or higher relative to the pre-treatment level. So we have 3 groups: an increased group, that if there is an increase in the CA153, non-increased group if there is no significant increase or decrease, and decreased group if there is reduction of the CA153 more than 10%. Of course, comparing with the pre-treatment level. Our result showed that there is no significant association between the age of the patient at the time of the diagnosis of metastasis with the level of the CA15-3 at the time of pre-treatment reading. Regarding its association with the metastatic site number, metastatic lesion number, we find that CA15-3 level significantly higher in patients with multiple metastatic lesions comparing with patients with single metastatic lesion. Regarding the association of this tumor marker CA15-3 with the metastatic site, we found that patients with lung metastasis or liver metastasis have higher, significantly higher level of CA15-3 comparing with those with no lung or no liver metastasis. While for the brain metastasis, there is no significant association between the patient with brain metastasis or no brain metastasis. Additionally, we divide the patient into molecular subtype of breast cancer according to the most recent classification, molecular classification, that based on the Ki-67 more than 20% as a count point to differentiate between luminal B luminal B from luminal A. So patient with Ki 67 more than 10% belong to the luminal B, which of course has worse prognosis comparing with luminal A. Okay, so our included patient, we have luminal A, luminal B groups, luminal B, HER2 enriched, and triple negative groups. Our results showed that a patient with luminal A, which luminal A and luminal B significantly associated with higher level of CA15-3 at the time of diagnosis, comparing with other subtype of breast cancer. And this could be related to the nature of the luminal cell, mature luminal cell, that show higher expression of the estrogen receptor and progesterone receptor. Additionally, also, we found that this increase in the level of the CA53 was associated with significant decrease in the level of CA15-3 after the systemic therapy in luminal A and luminal B group, comparing with other group of the breast cancer, I mean triple negative or HER2 enriched. And this reduction in the CA15-3 in luminal A was correlated very well with the achievement of the good response, partial response or complete response after reduction of the CA15-3 in patient with luminal A and luminal B. So there is significant association with the response to the therapy with the degrees of the CA15-3. For the survival study, there is no association or significant, no significant association between the patient level of CA15-3 at the time of diagnosis with the progression-free survival, as you can see here in this figure. There is no significant association between the level of the CA15-3 with the survival. However, we found that the mode of changes of the level of CA15-3 is significantly associated with the shorter progression-free survival. Patient with an increased group, this is the increased group, that patient who showed an increased CA15-3 level after systemic therapy, whether it is endocrine therapy, chemotherapy, have significantly shorter progression-free survival comparing with those patients with decreased group or non-increased group. And this changes was not found only in the luminal subtype, but also found in this is in luminal subtype. These finding in the luminal subtype, I mean luminal A and luminal B, and again the same changes or significant association was found even in patient with triple negative subtype of metastatic breast cancer. So we suggested that the mode of changes of the CA15-3 level is correlated very well with the clinical therapeutic response and survival advantage rather than the pre-treatment level of CA15-3 in metastatic breast cancer. And so we suggest that measurement of the CA15-3 level at regular interval after starting systemic therapy that showed equivalent quality with the medical imaging at lower cost. This could predict clinical response and could replace imaging examination like CT scan, PET scan, MRI that done routinely for monitoring response in patients with metastatic breast cancer, especially for luminal subtypes of breast cancer. Thank you very much for listening. This article has been published in the Journal of Medical East Journal of Cancer last year.